Max Wardell, overheadathletics.com, back in our third part of our UCL series. And we're talking about management of torn ulnar collateral ligaments, the UCL. If you remember from our first video, and if you haven't checked that out on types of UCL tears as well as prognosis for UCL tears, make sure you go back to that video and check it out. We'll put a card on the screen. If you remember from that first video, the ulnar collateral ligament has two bundles. The posterior bundle, not so implicated in the throwing athlete, and the anterior bundle, which runs from that medial epicondyle to the sublime tubercle on the ulna here. That's the component that usually gets torn in our throwing athletes as their arm lays back into a valgus stress and external rotation in the acceleration phase and late cocking phase of the throwing motion. We assess this in a few different ways, and if you haven't viewed our second video in this three-part series on assessment, I want you guys to go back and check that out because it's very important to make sure that you're treating the right structure, and structural localization around the elbow is very important because we have the triceps that bifurcates and comes around right into that same area. We have all our forearm flexors that overlay the UCL. We have our ulnar nerve, which overlays the UCL this way, and we have our pronator teres muscle, which comes around this way, all attaching in that same area. So utilizing manual muscle tests, lengthening muscle length assessments, as well as valgus joint play assessments are very, very important. And then using our palpation assessment and looking at the location of the soreness is always a very important concept. The UCL generally, if it's damaged, gets pain right localized around it, and a lot of times we'll get cramping the forearm as a result or shooting into the fingers as a result. We're talking about manual therapy. We want to make sure we're managing this condition properly from a soft tissue perspective as well as from a joint-related perspective. And if you remember what we talked about in the first video, if you have gapping at one side, gapping which tears the UCL, compression at the other, we can actually deal with some radiocapitular type of symptoms with compression, especially in our young athletes where they actually get compression of that cartilage, develop Panner's disease, which we've covered in another video. So Panner's disease is something that we get where we get osteonecrosis and breakdown, and we get some chondral defects and chondral breakdown as a result of avascular necrosis. So check out our video on Panner's disease if you aren't familiar with that condition. So we're going to talk about managing this in a few different ways. Soft tissue management is very important. When we manage the soft tissues, we want to have the athlete in a position where they're not in valgus. So I have actually a wedge under here, which we utilize often for thoracic manipulations and mobilizations, but it actually props him up nicely so that his arm's not tensioning that UCL. So we take the valgus out of it by utilizing the block here. And then we can start to apply some two-hand techniques where we're just starting to move sliding surfaces on each other in the elbow, get the elbow used to some pressure, and we can utilize this through the muscular components in both our athletes who have partially torn UCLs, who are doing a conservative approach where they're not getting surgery and they're going a rehabilitation route, as well as our post-operative UCL tears that have undergone Tommy John surgery or UCL repair. And I'm just kind of working through the tissues. Once we've done that, we can work into our functional massage. And I've made a video in the past on functional massage techniques for the medial elbow, but I like to utilize some flexion and extension. I'm not going to go through a full therapy session here with Chuck, but I'm going to give you an idea of kind of what we do. So we'll do the dummy thumb or the dummy finger technique where we use the opposite hand or the contralateral hand to actually apply our soft tissue mobilization force. And then we're going to go through our functional massage where we incorporate joint movement and no sort of skin sliding. So there's no skin sliding here. It's pressure on the tissue. I'm not taking contact off, and I can use a little bit of supination if I want to hit the pronator teres. And I'm just working through the tissue. Now, if I find that somebody has more of a tricep insertional soreness, I will come right where that medial portion of the triceps tendon attaches, and I'll do flexion. So I'm lengthening. We talked all about it, the different styles, whether you're lengthening or shortening, but I'm lengthening the tricep here with elbow flexion, and I apply my stretching and mobilization, soft tissue mobilization force as I do it. Now I'm working into the FCU. And I can easily spend some time in a long lever position where I'm working in the forearm flexors and managing some tonicity and stiffness through these muscles as I work here. After I've kind of warmed him up to the touch, got him working a little bit, got him into some different motions, and keep in mind, this is also passive range of motion while I'm doing it. So I'm actually getting a nice amount of passive range of motion to the joint, which he may be guarding, not moving a whole lot. So just moving the joint is going to pump some fluids through the joint and allow that joint to become lubricated, and some of the kind of stagnant chemicals, cytokines, and other chemical waste products that are in the area can kind of start to move out of there. And we know that when we have damage to ligaments and tendons, we get this inflammatory storm where we get the tumor necrosis factor alpha, we get the interleukins, all these different things that are going to irritate inflamed tissues in the area. And just by moving the joint and moving these tissues, we can start to flush that area a little bit. But we want to talk about joint mobilizations, decompressing the joint a little bit in this video as well. So that's what we're going to move on to here. One of the most important things to manage in our individuals who have ulnar collateral ligament injuries, whether that's a partial tear, whether that's just some fraying, whether that is just a little bit of an overstretched ligament, just painful in general. One of the most important things to manage is elbow extension, terminal elbow extension. What we've done here is we've taken that very same wedge that we used to prop him up out of that valgus position, and now we've got him into a little bit of flexion here, a little bit of shoulder flexion. Now I can always pin his shoulder too. Chuck's a big, thick guy, so I don't actually have to put something underneath his shoulder. His shoulder is going to be stabilized by the table there. What I'm doing is I'm actually going to supinate him, and I'm going to pin him into supination by rolling him this way. Once I've rolled him this way, he's stabilized on the proximal portion of the arm or the forearm by the wedge, and his shoulder is stabilized onto the table because he's a bigger, thicker guy. And in your skinnier athletes, you put something up under the shoulder. And if I don't get the mobilization feel that I want here, I could still go back and do that. So what I'm going to do is I hold him into supination. I hold this component of his distal forearm down, and then I'm going to come just off the olecranon here. I'm going to come right off of that, broad hand contact, and I'm giving him a ventral glide, or a glide forward towards the table. Basically, what I'm doing here is I'm mobilizing for extension. I'm stretching the anterior component of the capsule, because what we find, and you're not going to do this in everybody, you're going to do this in the people that have limited elbow extension like Chuck. We've done a whole video on how to assess elbow extension. We've done videos on elbow extension self-mobilizations, as well as multiple videos on table mobilizations, and this is one of our favorite ones in the painful elbow. So I'm pinning him. I'm here. Like I said, I only apply this if they have limited elbow extension, and then I'm giving him a nice ventral force. I can start with just some grade 2 oscillations, grade 3 oscillations, and then I can give him a sustained end feel or end range sustained mobilization. If I feel like he's guarding, I'm going to have him do a bicep curl into the table lightly. Go. Relax. Once he relaxes, I can take up more slack. And I like this because a lot of times, especially in our athletes who have had chronic damage to their UCL, a lot of these athletes don't like terminal end range extension because they get posterior impingement, because they have osteophytic change and osteophytes built up on that olecranon process. So we can take them out of terminal end range where they still have a little bit of gliding capacity anteriorly of the humerus, and we can start to apply this mobilization. Now, a lot of times we need to make sure that we're not putting them in valgus when we do it, because that'll tension, once again, the inside. If we find that they don't really tolerate it well in supination, we just pronate them, and we try the same exact technique there, although we find that supination generally works a little bit better to actually get some good mobilization. And then we take them back after and we say, oh, wow, about 5 degrees, because Chuck has thrown his whole life. he's a little limited in elbow flexion, as many of our throwers are. If that's still not getting the effect we want, we start to apply a traction force, and I'm holding him here on the 4th and 5th finger side, but I'm actually gripping his radius. So I'm actually gripping in this fashion to grip his radius, just based on the way my hand technique is. Now, if I have a tech or another therapist, I can have them use a grip like this, a quack hand grip or a lumbrical grip on that radial side, and they give me a traction. That's going to traction this radial joint, traction away from the humerus, which, as we've talked about, can sometimes become implicated with a compression-related injury. So here I'm holding that joint, and I'm holding that bone, giving him a nice traction, pin the traction first, then I once again apply either an oscillation or sustained hold mobilization. I can also come here and just stabilize distal humerus, driving that way, and pull with my body away just to get a nice little traction of that radiocapitular joint, which is also something that we have to manage in our throwing athletes. So elbow extension is very important. Generally find that elbow flexion is not as limited, but we can manage that as well. Let's show you that technique. Elbow flexion, let's say he's limited to here. Chuck actually has pretty good elbow flexion, although still a little bit limited in elbow extension. We'll probably never get him all the way into, equal or symmetrical side to side. But let's say he stops right there, and that's the extent of his elbow flexion. From this point, I can just do some oscillations. We find that a lot of time these oscillations and deflection really don't feel great. A lot of times people will get impingement on the anterior side. Maybe they have some osteophytic change there as well. Maybe they just don't like this repetitive movement. What we do in that case is I actually use my shoulder to drive him forward. So here, I take my shoulder, I take my hands there, so my shoulder can drive him into flexion. My hands are going to pull this way to actually give him a little bit of traction to open up that joint. So Chuck, don't let me pull your body. Just relax your arm. So I pull and I drive my chest forward to give him a nice little flexion mobilization, and I can do oscillations with my arms or oscillations in terms of angular motion. I can have him push into me to activate the tricep, push, 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 relax. If I feel like he's guarding, take up the slack, push, relax. But it's a traction mobilization to the ulna away from the humerus as I mobilize him into flexion, we find is very, very effective. But you can always just do your oscillations here, grade 4 or grade 3, to start to improve that motion. Now, while we think it's always important to manage the shoulder, make sure the shoulder's as strong as possible, make sure the shoulder has full articulation inside the socket, we're focusing on the elbow in this video. And when we focus on the elbow in our torn UCL or our UCL injuries, our torn UCL athletes, we often like to apply instrument-assisted soft tissue mobilization. In that case, I like this tool pretty well. It works very well to get into this area. Now, I've got a little bit of my mobilization cream on there. One thing to make sure is that you watch out for the ulnar nerve. So if they've had UCL surgery and they left the nerve in there, it'll be the same as Chuck's, which runs right between this bone and this bone. And if I kind of strum over that, it doesn't always feel good. So I have to be very careful in how I apply my instrument-assisted soft tissue mobilization. But I also want to start to kind of look at where the UCL is and apply it there. Now, understand that if you had a ulnar nerve transposition, where they moved the ulnar nerve, which often they do, as you can see here, where they moved my ulnar nerve in front of the medial epicondyle, you want to watch out if you apply any sort of instrument-assisted soft tissue mobilization in that region. So here, I like to use just nice small strokes, and this can assist with some collagen fiber alignment I'm using the diffuse edge, and once again I have him propped out of valgus, and I can start to alter his position of flexion depending on what kind of tissue I want to hit, and I'm just kind of working through the area. Now, a lot of times we'll see that athletes need to get managed a little bit more in these anterior tissues as they get into the exercise component of the therapy regimen, and that is the next video that we will cover. So part 4 in this 5-part series is in regards to exercise. That's what we'll talk about here in a little bit. So we like to use instrument-assisted soft tissue mobilization, moving into the more focal aspects of the tool as we go, just kind of getting into the elbow. Anywhere I feel it's a little gritty or isn't moving as well, I kind of target that area. But I will hit this anterior aspect, pronator teres, and I have to be very careful around that medial epicondyle, because if I hit that really hard, it doesn't feel very good, especially if anybody has a medial epicondylitis in combination with their torn UCL. So essentially, that's how we start to manage it. There's a lot of different techniques and ways you can use these tools, but just starting to provide some input specifically into that UCL is often very effective, especially if I've already managed elbow extension, flexion, and provided some radial traction techniques to alleviate that lateral side of the elbow. If you haven't checked out the first few parts of this series where we've actually done some assessment of the UCL in part 2 and part 1, where we talked about prognosis as well as different types of tears, you need to go check those out to get a better understanding of a comprehensive approach to torn UCLs and managing those in our throwing athletes. These are some great manual therapy techniques that you can start to implement, as well as many others that will target the shoulder as well. However, exercise is very important because through the research we've seen that stronger forearm flexors, stronger pronator teres, stronger triceps all protect and have a protective effect on the ulnar collateral ligament as it encounters valgus during the throwing motion. And then we need to talk about how to protect the UCL through some really simple activities and really simple assessment techniques for the throwing motion, and that'll be in part 5. So you do not want to miss part 4 and 5. That's why you want to make sure you subscribe right now. Hit the like button. We want to get these out to as many therapists and as many athletes as possible. And the best way for us to do that is if you guys assist us by liking that video, and that really helps us a lot, but it's also going to help athletes and coaches and manual therapists who are out there. So hit the thumbs up. If you have any questions, drop them in the comment section. Hopefully we'll answer them in parts 4 and 5. But otherwise, we will see you in part 4 of this 5-part series.